Hey everyone, welcome to our Fiscal Cliff or Fiscal Avalanche webinar. I'm David Glaser. I'm here with Katie Ilten, Catherine London, and Jim Platt, and we're going to walk you through a whole bunch of stuff today. Now, Katie Ilten was saying that this webinar should be sponsored by Bayer in light of my aspirin comment and how much you're going to need one when your hair hurts as we go through this stuff. I think that might be her flu talking. So we've brought Katie out of quarantine to start us off here. But first, a couple quick announcements. If you want to ask it a question at any point in this webinar, you can type it in the chat box. If you are unfortunate enough to have managed to move your screen into sort of full screen mode and you can't see a chat box, you can always use the Alt-Enter in combination, or should be able to bring your screen back up. Or if you hover over the little bar at the top center, that should bring your chat box up and allow you to ask questions. It often slows down over the lunch hour. If I become all garbled and you think it's not just me being confusing, you can always dial into the number that Robert is typing in the chat box corner. And if you have a sound problem, I would encourage you to do that because the internet slowdowns aren't in our control or yours. Finally, this is our February webinar. The calendar may say January, but this is really our February webinar. We rushed it because of the stuff. Webinar will be March 13th, and we're going to do RAC appeals. And actually appeals generally, but with a focus on RACs and tips for kind of working on the appeals system. And just for fun, since you signed in today, Jim suggested a special code. We're going to use the code Avalanche. If you register with the code Avalanche, next webinar is free. That will undoubtedly be an avalanche of, okay, well, let's leave that alone. All right, so enough of the junk. I'm going to turn it over to Katie Ilten, who's going to talk about the doctor fix and then and adjustments to DRGs. And after that, we'll come back and I will talk about the changes to the overpayment laws.
And I'll ask David to advance the slides so that I do not poison him. All right, so this is the big...
What's it like working with a germaphobe?
It's very isolating. So I represent the 20% of Americans who right now have a cold and who apparently are ostracized by their coworkers because they don't want anything to do with them. All right, so the doc fix is the big headliner for the fiscal cliff legislation, although you will find throughout the webinar that there are lots of items buried in there that are helpful to know that were not necessarily talked about in the press. So we'll deal with the obvious one first. So each year for the last several years or so, there's this statutory requirement that's called the sustainable growth rate that's supposed to be triggered to require CMS to reduce physician payments in order to keep up with the rising costs of healthcare. And this year, I think the reduction was upwards of 26 or 27% cut to take effect on January 1st. And again, as in prior years, Congress didn't permanently fix the sustainable growth rate by getting rid of it. Instead, they did a one-year fix and said that at least until 2014, there will be a 0% reduction in payments to physicians. So that's the temporary fix now. This issue is going to come up again next November or December. What's interesting about the doc fix this year is that it comes with the fiscal cliff legislation, which means we get to see how Congress proposed to make up for the $26.5 billion that this doc fix is supposed to cost the Medicare program. And go ahead, David. The big chunk of, I think about 10.5 billion of that 26 billion is going to be made up now through downward adjustments to hospital inpatient payments beginning in 2014 and going on until 2017. People are asking why hospitals? Why is this getting pushed off on hospitals? And CMS has come up with the sort of creative response or rationale of saying that a while back when we switched from the cost-based reimbursement to the DRG payment, there was an increase in payment that didn't necessarily reflect changes in the patients that hospitals were seeing, and were really just because of coding adjustments that didn't reflect changes in the case mix. And so CMS said, well, that increase in payment was actually an overpayment to hospitals. So we're going to try to recoup that amount by reducing inpatient payments going forward. What's interesting about this is that CMS has actually been reducing inpatient payments for a while now to make up for this so-called overpayment. And just a few months ago in the Inpatient Prospective Payment System final rule, back in, I think, October, CMS said, okay, we're done. We're done fixing this, and we don't need to go forward with recouping this overpayment. But then came the fiscal cliff, and we needed another reason to make up for, or we needed room to make up for the doc fix. And so it turns out that indeed CMS is not done recouping money from hospitals, and they're going to go forward with this fix beginning 2014. Now, we don't know the exact percentages. We'll have to look for that in future rulemaking, but this is a big deal for hospitals.
And to me, it reflects part of a trend that I'm seeing, which is characterizing what we would call proper payment as overpayment. You know, if you see headlines about how the electronic medical record is driving up costs, what they're saying is it's driving up costs because there's now higher E&M coding. Well, in other words, the codes are, I would say, more accurately describing what's in fact occurring, but that's being characterized in the media as an overpayment, and that's kind of the same thing here. The system is set up that way, and it's now being labeled as an overpayment.
All right, hand it over to David, who has been itching to talk about this topic since it came out.
This is true. Actually, itching in a sort of dreaded way, because I am trying to figure this overpayment thing out. I have to admit, this has been a humbling experience for me. I'm still not sure I totally understand this thing. Well, I'll try to walk us through it as well as I understand it. This is where I'm thankful to have a lot of brain power here to help me out when I don't know what I'm doing. So we'll go through that. So first, the 30,000-foot view of the change, which is there's a section in the Social Security Act, for those who are into technical stuff, it's Section 1870 of the Social Security Act, and it has been there for a long time. It limits recovery of overpayments. And so the text, which we'll look at in a minute, has a provision that limits the government from recovering certain overpayments when they occur subsequent to the third year following the year in which notice of such payment was made. And we'll look at the section shortly, which is why you're going to want your aspirin. Well, they changed the third year in the law to the fifth year. That's the only change. Just crossed out third and replaced it with fifth. Actually, I guess it's changed in two places, but we'll look at that in a moment. And so the question is what this means. Now, there are a number of problems here. The statute is extraordinarily difficult to understand. This is where I'm really, really glad. I first looked at this statute when I was a young pup lawyer back in like 1994. And I thought I understood it then, and then I realized I didn't. And in 95, I thought I understood it, and I realized I didn't. By 1996, I thought I understood it, but it's now clear to me I still did not understand it the right way. Katie Ilten and Catherine London have been pushing me on this, and I'm really thankful for that because I think we're slowly getting to the place where I get it. But I'm still not sure, and this statute is extraordinarily hard to read, and I think one of the things I believe right now is that the way most people read the law isn't consistent with the language of the law itself, and for providers, that's probably a good thing. Now, as we talk, it's going to be important to remember the legal hierarchy. Statutes trump regulations, which trump manuals. We're going to have all three of them coming up here. This next point, and I know there are some reporters on the call, and I would make a personal request that you don't highlight this next bullet point. In fact, maybe just omit it. I'm not sure that the way that the law is applied is actually consistent with the actual language of the law. And a lot of the speeches I give focus on this, but this is one of the times where I think the law as applied might be kinder to hospitals and physicians and other healthcare entities than the law is itself. So we'll explore that. So what are the big questions? How do we apply this change today? Is this change going to result in regulatory rules changes down the line, and do we care? So let's look at the legal framework in a little more detail. So there are really two different laws that govern overpayments. The one we talked about, 1870, that changed, okay? There's another law, which we'll look at right after very briefly, which is called Section 1879. That law didn't change. So 1870 talks about when an organization or a person is without fault. 1879 uses a different framework. They said if you didn't know and shouldn't have known about the overpayment, it can result in waiver. Now, I guess three words I want people to kind of think about as we talk are recovery, reopening, and overpayment. All right? The word reopening doesn't appear in the law at all, but it appears in the regulations. The word recovery appears in the law, And the word overpayment doesn't appear in either of these two, but it's going to appear in another statute we're going to talk about in a little while. All right, so just kind of think about recoveries as being different from reopening as opposed to being different from overpayments, and we'll explore that. So the law sets up this time limit on recovery. The regulations set up a limit on the government's ability to reopen claims, but to the best of my knowledge, don't ever talk about limits on recovery. And then the manuals are going to limit both reopening and recovery. So now that I've thoroughly confused you, let's look at this substantively. So first, let's look at the impossible to read section. So, there shall be no adjustment, as provided in the paragraph above, nor shall there be any recovery when any case where incorrect payment has been made, and then we can skip the parentheses, with respect to an individual who is without fault, or where the adjustment or recovery would be made by decreasing payments to another person who is without fault and is entitled to under this subsection. Now, we've already covered a lot. So this is why this is really confusing, but I want to pause for a moment and note that it says, with respect to an individual, which suggests to me that the payment doesn't have to be made to the individual who's without. It could be talking about a payment made to somebody else, but about the individual who is without fault. If the adjustment would defeat the purposes of this title, so the Medicare law, or would be against equity and good conscience. Okay? So, if the adjustment defeats the purpose of the title or is against equity and good conscience, you can't recover the money. Now that we're not done with the paragraph yet, just the sentence. Adjustment or recovery of an incorrect payment against an individual who's without fault is deemed to be against equity and good conscience if A, the incorrect payment was made for expenses incurred for which payment wasn't supposed to be made because it was reasonable in necessity. So this is referring to the law, and it's the section of the law that talks about services not being reasonable and necessary. Okay? And, so we have to meet both of these two tests. The secretary determines that the payment was incorrect, was made after the third year following the year in which notice was made. And this is what changed, and now the third year becomes the fifth year. Except that the secretary can make the 5-year period shorter to not less than 1 year if he finds the reduction is consistent with the objectives of this title. Now, so if you read this really confusing sentence, what it's saying is that if you're trying to recover against someone who is without fault, then it's deemed to be against equity and good conscience if you do it after the third year. So if I read this sentence the right way, I think what it's saying is that you have to arguably be without fault in order for that time limit to apply. Now, that doesn't actually make a ton of sense, but that's, I think, kind of arguably what it says. That's not the way courts have applied it, all right? And we'll talk a little bit. What courts have actually said is if you, after the time period lapses, you are deemed to be without fault. I'm just, like I said, not sure that that's what the statute said, and for the reporters online, I'd appreciate it if you just skip that part. All right, so I don't know what the statute says for sure, I just know how it's applied. Okay, so speaking of application, how does 1870 work? And this is one of the things that makes the statute really confusing. It only looks at the year in which payment was made. All right, we don't care about the date at all. Most of the time when you're thinking about a recovery period, you might think it's 4 years after the date of the claim. That's not how this works. So let's take a payment that was made last week, all right, if it was made on January 4th of 2013. Under the new provision, the government can recover for 5 years after 2013. So we're going to look at all of 2013 as fair game. So the easy way to do this is take out your hand. You'd say they can recover in 2014, 2015, 2016, 2017, and 2018. So any of those 5 years are fair game because those are the 5 years that occur after 2013, the year in which we got payment. So they can recover any time through December 31st, 2018. Under the old provision, recovery would have been cut off at December 31st, 2016. All right? So that's the change. If the payment had just been a couple days earlier, we'd go, all right, it's 3 years after the year in which payment was made, same exercise, recovery can be made up through December, through 20, 16. Now, what's one of the things that's really weird about this provision, if the payment had been made 5 days earlier at the end of December 2012, assuming the new provision applies, we lop a whole year off the recovery period. And that's one of the things that's really crazy, because remember, we're only looking at the year in which payment was made. So operationally, what this means is that a payment made on January 1st can be recovered for 6 years. A payment made December 31st can be recovered for 5 years. And a payment made, July 1st can be recovered for 5.5 years. That's crazy. So you'll see all kinds of people who say that the recovery now went from 3 years to 5 years. That's really misleading. And it's because it's hard to explain this. So simplicity is beating accuracy. It's really 5 years after the year in which payment was made, okay? Now, I don't want to spend very long talking about the other section of the law, 1879, because it didn't change, but I'm throwing it up, and actually this will make you want to throw up. So I'm not going to read through this because it's very difficult to understand. Just know that it's another statute that basically says that if you don't know and reasonably can't be expected to know that something is an overpayment, this law gets you off the hook, okay? So you just kind of know it's out there. I included it in your materials so you can read it at home if you're geekier than I am. It's another fairly difficult to read statute, but way easier to understand than 1870, okay? And this law, like I said, did not change. So now, out in a lot of people are saying that this change to the law isn't meaningful. Because there's an argument to be made that they're right. I'm still trying to figure this out. I'm worried about this change, and I am hopeful that people who say that this change isn't a big deal are right. So people who are saying that make the following argument. So there are regulations, and you can see them right here, that limit when a Medicare contractor can reopen a claim. And so those regulations say that a contractor can reopen either an initial or a redetermination on its own, either anytime within 1 year, they can do it for any reason they want, okay? Anytime within 4 years from the date they make the determination. So notice here we're doing 4 years from the date of the determination. So 48 months from the date of the determination, not, we're off that weird year in which payment is made stuff. If there's good cause, and we'll look at good cause in a moment, or they can go back anytime, and they can reopen at any time if there's reliable evidence that the initial determination was procured by fraud or similar fault as defined, and we'll look at that in a minute. So basically, unless there's fraud or similar fault, a contractor can only reopen a claim for 48 months, all right? So let's take a quick gander at what our definitions mean. So here's good cause. So good cause exists basically when there's any new or material evidence that wasn't available at the time that a determination was made. So the bottom line is, this is a fairly loose standard. They need to have some sort of new or material evidence that might have resulted in a different conclusion, or that shows on its face that an obvious error was made. So the good cause test is pretty easy for the max to meet. I have seen very few cases, in fact, I don't think I've ever been involved in one, where someone found that there wasn't good cause for reopening a claim. This is just another slide that's there kind of for your edification. It's the rest of what good cause is. I'm not going to read through it. A more interesting definition is similar fault. So remember, if the phrase fraud or similar fault appears in the regulation, I at first couldn't find the definition of fraud or similar fault, and the reason is there isn't one. They don't define fraud or similar fault. They just define similar fault. And the definition says that it's obtaining, retaining, converting, seeking, or receiving Medicare funds which a person knows or should reasonably be expected to know that he or she or another for whose benefit the funds are retained, obtained, converted, sought, received the money it is not legally entitled. This includes, but is not limited to, failure to demonstrate that he or she filed a proper claim. Now, that, to me, doesn't sound like fraud at all, because fraud has an intent element. This just sounds like you knew you weren't entitled to the money, or you should have known you weren't entitled to the money. And so this definition should scare the socks off of you, because this would suggest that basically almost any overpayment is similar fault, and under the regulation, there's no limit on recovery. Now, I think that this reads the word fraud out of existence. I can tell you I have never had a problem where someone has argued that a simple mistake allows a recovery back. Well, I've had it argued. I've never lost, I should put it that way. I've had cases where the government has taken that position, but in front of an ALJ, we've never failed to have that 48-month window applied. But if you read this text of the definition of similar fault, it should make your blood run cold, okay? Now, here's the good news. So we've looked at the statute, and we've looked at the regulations. Here's what the manual says. So the manual has an example of how 1870 works. And this is in the Financial Management Manual, Section 70. In an example of when you don't make a recovery, you don't make a recovery if the provider was without a fault with respect to an overpayment. And look at the red here in parentheses, or is deemed to be without fault in the absence of evidence to the contrary, because the overpayment was discovered subsequent to the 3rd calendar year after the year in payment. So here is the way that the law has always been applied in my experience, which is you're deemed without fault after 3 years after the year in which payment was made. Okay, so that's what the manuals tell Max to do. And so now presumably that manual language would get changed to be 5 years after the year in which payment was made. Is this manual language consistent with the law? I think that's a fair question, but this is what the manuals say. Now, there's also manual language that talks about carriers not reopening decisions if they haven't acted within 48 months of the date of their determination. So in this text, unless there's fraud or similar fault is present, you can't reopen a claim unless you've taken some action that can be documented, questioning the correctness of the claim within 48 months of the date of the determination. Now, what that action would be isn't spelled out here. Is sending a letter saying we're looking at this claim notice of action? I think the government would argue it is. I don't know of many cases yet exploring this one. I'm in one right now where I think we will be looking at exactly this question, and more on that in a moment. And then finally, there's one other section of the manuals that says that a provider is liable for overpayments unless it's found to be without fault. And what's interesting here is that this particular description doesn't say anything about being deemed to be without fault after the passage of time. They skip it here. It appears in, it appears in section 70, but when you skip ahead to section 90, they just sort of skip it. Why? I don't know. All right, so let's try to figure out operationally what all of this means. So the first question, are you deemed to be without fault after the passage of time? It's a good question. Right now, I would still say that the answer is yes. I feel a little bit of a shiver in my spine when I say that answer is yes, but I think, that seems to be how everyone is implementing 1870. I think after the passage of a certain amount of time, you're deemed to be without fault. And net passage of time went from 3 years after the year of payment to now 5. That's what I think the answer is going to be, all right? So if a Medicare administrative contractor asks for records, and they're looking today for records from January 10th, 2009, can they do it? My answer to that would be no, they can't, because the limit on reopening should prevent them from going back that far unless they can say there's fraud or similar fault. How do we get there? Well, today is January 16th, 2013. So 2009 is more than 48 months ago, and so they can't reopen absent fraud or similar fault. Well, can the MAC say, but wait a minute, there's this new law, and that trumps the regulation? And I would say no, they can't, for a couple of reasons. First, I think this law doesn't really apply it doesn't apply to the same topic area as the regulation. The law doesn't mention the word reopening at all. The regulation is focused on reopening. So I would say that law doesn't apply to this regulation. They're covering different animals. And moreover, the law isn't allowing any recovery. It's creating limits on the recovery. And so I don't think that law trumps or contradicts or is in any way inconsistent with the regulation. And then, in addition, the law lets the secretary be more lenient if the secretary so chooses. So she has the right to be more lenient. And you could say with a very straight face, the regulations do just that. So I'm not worried about Max being able to reopen claims more than 48 months ago, unless or until that regulation is changed. Okay? So that's the first thing. So now let's say that a MAC has requested some records from January 2009, but you don't yet have the overpayment notice. This is what I'm working on right now. Let's say that they're going back. Let's say you had this notice for a year. You've been sitting here and you know the audit's underway and nothing's happened. Can they recoup? Now, this is a more interesting question. So the first question is, does the amendment apply? And that is a super interesting question, and I'm not going to pretend to be able to answer it right now. The effective date of that amendment was immediate. So does it apply to actions that began before? I mean, how does it work? Does it trigger today and now the timeline is the time limit is extended for claims that were being looked at? There are arguments on each side of this one. The argument against it applying is that there's generally a presumption against retroactive application of laws. The argument for it is you'd say, well, look, this is a limit on how far back you go, and it's not a retroactive application of the law. We're going to have to see how that one plays out. The other interesting question here is, what constitutes reopening? Is a claim reopened when the carrier says to you, we're looking at this claim? Is that the reopening? Or is the reopening when they say, we want the money back? Is just telling you we're looking at the claim a reopening? And if so, can they tell you that they're looking at the claim and then wait 5 years before they get around to getting back to you? That's an open question, and I don't know of many cases dealing with it. If someone believes that this claim has been reopened, then the limit on recoupment is going to come up. So this is this is when I'm teeing up, and I don't know the answer to this one. Now, RACs. I've seen some headlines that say RACs can now go back 5 years. That's another one I feel comfortable saying that's inaccurate. RACs can't go back 5 years. RACs are a whole different ballgame. Why? Well, a few reasons. First, there's a statute that governs how far back RAC can go, and then more importantly, the statement of work, which is more restrictive than the statute. So the statute allows RACs to go back 4 fiscal years after the year of payment. Now, as if we haven't been confusing enough with our 3 years after the year in which payment was made and our 48 months, here's a whole different standard. Fiscal years start October 1st. And so this is 4 fiscal years after the year of payment, our third test for those who are keeping track. But I think you can blow that test off because right now the RAC's statement of work limits RACs to going back 3 years, and that's just 3 plain old calendar years, all right, using dates. And so anytime a RAC tries to go back more than 3 years, I would say that they can't, pound sand, and I would fight them on that. And the headlines that say that RACs can now go back more than 5 years, I think are just wrong. So I think the statement of work carries the day. We don't have to worry about RACs. Okay? Now, here's the question that's giving me a bit of conniptions. And that my usual aggressive side is feeling a slight arrestor. An arrestor might be the right choice of words here. So here's the issue. You discover an overpayment today. How far back do you have to go? Do you have to go back 48 months to refund the money? Or is it 5 years after the year in which payment was made? Now, remember that the Patient Protection and Affordable Care Act requires you to report and return an overpayment within 60 days of identification. And I think everyone is familiar with that. But in case you haven't looked at the definition of overpayment in that law lately, here's what it says. An overpayment is any fund that a person receives or retains under either Title 18 or 19, so Medicare and Medicaid, to which the person, after applicable reconciliation, is not entitled under such title. So the 4-star question is, if we know that the MAC can't reopen a claim, can we say with a straight face that there isn't an overpayment? And I think that there's a decent argument that the answer is yes. I would say if the MAC can't reopen the claim, we're entitled to the payment. We know the MAC can't come and ask for it anymore. So that claim is now past the window in which the government can ask for it. And I am not at all embarrassed making that argument. My one cause for concern is I can see someone making the argument, whoa. The fact that the MAC can't reopen the claim doesn't mean you were entitled to receive it. And in fact, the limits on MAC recoveries are like the limits we just talked about on RAC recoveries. There's a limit on how far back a RAC can go. There's a limit as to how far back a MAC can go. That doesn't mean it's not overpaid. Just because RACs can only go back 3 years doesn't mean something that's 4 years old isn't an overpayment. There's just a limit on how far back the RAC can go. There's a limit on how far back the MAC can go. It's still an overpayment. And the easy answer would be, well, if someone wants to make that argument, we'll let them. They can come back and ask for the overpayment. And the catch is, if we have failed to report and return an overpayment within 60 days, we're not merely liable for the overpayment, but we're now liable for false claims penalties, which would be, treble damages, and then $5,000 to $11,000 per claim. And so there's an interesting question here as to whether the claims would be one claim because you didn't refund the overpayment, or each unrefunded claim. And I think there'd be an argument it's each unrefunded claim. So you've got this giant penalty. If a whistleblower wants to make the argument, the statute limitations allows them to go back further, and we fail, the potential penalty is fairly astronomical. And I'm pretty comfortable saying 48 months is a decent window, but I feel like I have an obligation to say to everyone, there's an argument that can be made that the overpayment isn't extinguished until the presumption of the statute is triggered. And then if you really want to be particularly a nervous Nelly, you'd say that statute is written really poorly to boot. So that's when things get ugly in a hurry. So this is uncharacteristic for me because my usual position is fairly aggressive. And on this one, I have a bit of trepidation. I think ultimately I come down to I'm probably okay with saying go back 48 months. But there's going to be an asterisk next to it that people need to understand. I think that someone can make an argument that for 5 years after the year in which payment was made, and then there's even another asterisk next to that. Okay. The other obvious point to think about here is the chances of the rules changing going forward are quite high. Now that the statute has changed, will the government come in and try to say we're gonna extend this reopening period? They might. The good news is it often takes forever for rule changes to go through. So where am I coming down on this 48 months? I don't know. I have not come down definitively. I think I'll be telling people I'm still happy with the 48 months, but you need to know that there's some peril that comes with it. All right, that was long and convoluted. Now everything else we do from here is going to go really quickly and be mostly much less convoluted. So I've got the first one, which is ambulance payment. So there were a couple of changes, or really not changes, but extensions made to rules governing ambulance payment. Oh, and I will just remind people you can ask questions by typing in the chat box in the lower right. You can also just call us names if you want for having done that prattle. Okay, the ambulance payment. So there were some rules that allowed an extra payment of 3% above an ambulance claim in rural areas or 2% in urban areas. And that was set to expire at the end of 2012. That has been extended through December 31st of 2013. For purposes of this rule, if you're trying to figure out if you're rural, it's rural means you're outside of a metropolitan statistical area. It's the same test that's used in Stark. There's a website. I should have put the website link in here. If you're curious about this, I can email it to you. It's done on a county basis, and a county is either in a metropolitan statistical area or outside of it. Generally speaking, if a county has 50,000 people or more, it's metropolitan. As Jim has learned with a client, you can go from rural to urban over time. Counties can change. Okay. There's an additional extra payment that applied in super rural areas, which were areas that were the lowest 25% of population density when they rank all the counties by population density. And there's a base rate increase that was set to expire. That now continues through December 31st of 2013. And then also rural areas have a certain, get a different reimbursement for air ambulance. And there was a grandfather provision that said if you were rural on December 31st in 2006 and you had become urban, you were treated as if you were rural. And that's going to continue until June 30th of 2013. Also, as part of this provision, there are two big studies that CMS is required to do. So by October of this year, they have to look at both hospital and critical access hospital-based ambulances and try to study how their costs vary based on the hospital's characteristics. And it's clear from that the goal is to change the way that ambulances are reimbursed in both the hospital and critical access hospital setting. And then by July of 2014, there's supposed to be the feasibility of getting cost data from all ambulance suppliers to looking at cost data. And so they're looking at ways to get cost data from every hospital in the country. The bottom line on that one is changes in the air, not just on the ground for ambulances. I will now turn it over to Jim.
Thank you, David. I've got just a couple quick slides, and then Catherine London will be going through the rest of the slides. David reminded me that since his last topic was on ambulances, that makes me the ambulance chaser, so I thought that was particularly clever of him today. With regard to a couple other changes...
You have to give credit where credit was due, Jim. That one wasn't even me.
Couple other changes to note in the fiscal cliff legislation. One of the things that was in the president's budget, proposed budget last February, was to make an additional year of adjustments to state disproportionate share hospitals, and that ended up being included in the fiscal cliff legislation. So what this has to do with is that the federal government makes payments to the states, and then the states provide some matching dollars, and these special payments go to hospitals that have a disproportionately large number of low-income patients, such as patients covered by Medicaid and the uninsured. And this is one of the largest sources of federal funding of uncompensated hospital care for these hospitals that cover these folks. In the Affordable Care Act, that legislation reduced these payments by a little bit over $18 billion, and it reduced them through 2020. And the logic for reducing those payments was because we're going to have more coverage under the Affordable Care Act for people. There's less of a need to provide these additional payments to these hospitals because they will now have insurance for these patients rather than for them to be uninsured. So the Affordable Care Act reduced those payments through 2020. What the fiscal cliff legislation did, which by the way is called the American Taxpayer Relief Act, what that legislation did was bumped it out for an extra year. So it put that out for another year to garner some additional savings in this legislation. The second thing that I wanted to comment on that the legislation did was to remove the funding for nonprofit state health insurance co-ops. Under the Affordable Care Act, that legislation provided startup loans and grants for nonprofit health insurance cooperatives. And these were created under the Affordable Care Act to create a source of competition in states that are dominated by for-profit insurance companies. And this was included in the Affordable Care Act as a counter to the desire to have the public option. As you might recall, having a government-sponsored public option was a hot topic in the Affordable Care Act, and so this was put in as a partial compromise to not having that, to encourage these nonprofit co-ops to get going and to give them some funding. Well, the fiscal cliff legislation rescinded that source of funding. Co-ops that had already secured their funding in 2012, and there are about 26 of these or so across the country, they are not affected. They'll still have their funding. But those that were in the process of applying for the funding, or those that got formed but had not yet applied, they're no longer going to have this source of funds. And so media reports indicate that there are about 24 of these out there that were in the process of applying for funds or in the formation stages. They'll no longer now have the startup loans in order to get these things off the ground. And so that's the way that goes, and that will again garner some additional revenues that wouldn't otherwise be the case. So Catherine, I'll let you finish the rest of these up.
Thanks, Jim. So I'm tasked today with summarizing a number of changes that were also included in the fiscal cliff legislation. And we thought it was worth bringing your attention to some of these changes because they might affect many of you who are listening today. So first, the legislation reduces payment to hospitals for outpatient radiation therapy. And it's going to do this by equalizing the payment amounts between APC codes for levels 3 and levels 4 stereotactic radiosurgery. And this is really going to amount to about a $4,600 reduction for the code for level 4 services. And this reduction will go into effect for any services that are furnished after April 1st of this year. And we should note that rural hospitals, rural referral centers, tough to say, and sole community hospitals are exempt from this reduction. The law also reduces reimbursement for certain advanced imaging procedures, and it will do this by increasing the equipment utilization rate that's used to calculate the technical component for these advanced diagnostic imaging procedures. And we should note that for purposes of this reduction, advanced imaging refers to imaging equipment that costs more than $1 million. And so the legislation, what it did is it increased the utilization rate from 75% to 90%, which is going to result in a lower reimbursement under the fee schedule for these services. And this change will be effective 2014 and will apply to any services that are performed in physicians' offices and independent diagnostic testing facilities. So this change is expected to reduce reimbursement by $800 million over the next 10 years.
I'm just going to pipe in real quick to note, I know some lobbyists who were really amazed that a number of these changes were in there because there was no word of any of them before. That's true of the changes that Catherine just talked about. It's also true of the overpayment changes and stuff. And so it's just one of the interesting things about how sometimes change out of Washington can come very quickly and very unexpectedly. So it's just worthy of a note.
Yep, and we're mentioning a handful of the changes, but there are several additional changes that were included in the legislation that people are just not talking about, not even aware of yet. So next, thought we'd mention there are some other changes relating to therapy services that were included in the legislation. And the first one is the reduction in payment for multiple therapy services that are provided to a patient on the same day. So under current policy, CMS reduces the practice expense component for therapy services that are furnished to a beneficiary on the same date and by the same practitioner or facility. And I should note that this applies to what CMS refers to as always therapy services. So it includes a number of types of therapy such as, PT, OT, anything to ultrasound therapy as well. Under the current policy, the reduction was 25% in institutional settings and a 20% reduction in office or non-institutional settings. But now, effective April 1st of this year, they're going to apply a 50% reduction to any of these multiple or additional therapy services that are provided to a beneficiary on the same day. And this is going to be a very significant reduction. As you can see, it's going to lower reimbursement to providers by $1.8 billion, estimated over the next 10 years. Another therapy-related change included in the law was that it extended the exceptions process for outpatient therapy caps with a few changes. CMS currently sets an annual per beneficiary payment limit on outpatient therapy services using these two separate caps, one for physical therapy and speech-language pathology services and a separate cap for occupational therapy services. And the CMS allows exceptions for providers to receive reimbursement in excess for services in excess of the cap. And under the automatic exceptions process, any claims that for services that exceed the cap amount but are below this $3,700 threshold will still be reimbursed if medically necessary. And then for claims exceeding the $3,700 threshold, those are subject to a manual medical review. So the therapy caps were set to expire at the end of 2012, and the legislation extended these exceptions through the end of 2013 and also expanded the therapy services that apply towards the cap amount. So in particular, beginning October 1st of 2012, hospital outpatient therapy services were also included towards the cap amount, but now the legislation extended the caps to services that were provided at critical access hospitals. So providers and suppliers, there's not too many changes here. They should continue to submit claims using the KX modifier, which allows providers to request an exception for services that are provided beyond these limits. But note that there are additional services, the CAH services and outpatient hospital services that will apply towards these caps. So the law also extends certain hospital programs that were aimed at helping small rural hospitals. And the first is under the Medicare Dependent Hospital Program, which increases reimbursement to small rural hospitals where Medicare patients constitute a significant percentage of inpatient days or discharges. And this program was set to expire on October 1st of 2012, and the legislation extended it into October 1st of 2013. And then the other program is the low volume hospital program, which provides hospitals with fewer than 1,600 Medicare discharges and which are located 15 miles or more from the nearest like hospital, add-on payments that are based on the number of discharges. And under the new law, this payment adjustment is extended through the end of 2013. So the final change that we're going to note here is the legislation made some changes to the physician quality reporting system requirements. And in particular, it establishes a new way to meet the requirements by allowing practitioners to submit data to qualified clinical data registries. So under the PQRS, as many of you know, healthcare professionals will be responsible for reporting information to Medicare about the quality of the care they provide to beneficiaries. And the program provides incentive payments to practices that report data on these quality measures. But it's also important to remember that beginning in 2015, CMS is going to apply a penalty to practices that fail to report this information. So under the new law, or the new legislation, beginning in 2014, professionals will be deemed to have met the data submission requirements for the PQRS if they participate in a qualified clinical data registry. So we don't really know what this means just yet. HHS is going to be tasked with defining what a qualified clinical data registry really is. But basically, if any practitioners who are already reporting to any registries that fall within this definition, they're deemed to have satisfied the reporting requirements and wouldn't be subject to the penalties that start in 2015. So I think that was a very quick, high-level summary of many of the changes that they snuck into the legislation, and I will turn it over to David.
All right, so this is going to wrap up what may be one of our shorter webinars. We actually are under the time. Remember, so the upcoming webinar, I'm going to put in a plug for this because Katie Ilten has been working on RAC appeals with me for a while and does just a great job. She's cheap, she's quick. So she, Catherine, and I are going to talk about the appeal process and tips you can use to make your RAC appeals work better. We've been doing a ton of these lately, and I think that there are tips. So I would get the people in your organization who would benefit from knowing things about RAC stuff signed up. And remember, if you use the Avalanche code as suggested by Jim, this one will be a freebie. So that's on March 13th. There's only one question right now, and I think the question is fairly specific. I'm going to take the last part of it and turn it into a question, which is, hey, if Medicare is denying something is not medically necessary, we're being told we're not allowed to bill the patient for it. And I think that the answer to that is, well, it's going to depend. If you've got, it's going to depend a little bit on why the service was denied and exactly what's going on. If you do a service that's considered not medically necessary, and you've advised the patient that it may be not medically necessary and you get the ABN, you might be able to collect from the patient. But to some extent, it's going to depend on the denial, and the details of this question are fairly specific, so I'm not going to go into the rest of that on here. We'll deal with that. I'll contact the questioner personally. So thanks for joining us. I hope you can join us on March 13th. And remember, if you have any comments for us on the webinar, feel free to fill out the evaluation form. On behalf of Ms. London, I guess it's with our Catherines and Katie. So Katie Ilten started us off. Catherine London wrapped it up, and then Jim and I were in the middle. And so on behalf of the entire Health Law Group, thanks much, and we'll see you in March.